Okay, good morning, everyone. Thank you so much for waking up bright and early on a Saturday morning and giving us your attention and your time. My name is Valerie Chang. I am the Executive Director of the Hawaii COPD Coalition, and I'd like to welcome you all to our 6th annual COPD Education Day. We're very excited this year to have some new topics, including Dr. Christine Fukui talking about the exciting new therapies that are coming up. There are 54 drugs in the pipeline for COPD, and she's going to talk about some of them with us. There is a restroom out the door as you entered, to the right down the stairs, okay? And if anyone needs assistive hearing devices, they need to ask at the front desk behind registration and give their driver's license, and they'll get it back, or ID, and they'll get it back when they leave. Make sure nobody parks in POB 3. We can't validate for that, but any other validation, make sure you get it done at the registration so that you don't end up paying $30 or more. And some of you have asked how you can contribute and help support our efforts. In your packets, there is an envelope, and it is addressed to our organization. So if you'd like to contribute today or at any future date, you do have our address. There's also an orange sheet. Can someone hold up their orange sheet? That orange sheet can be filled out, and if you fill it out, that gives you one more prize entry drawing. Also, if you went to at least 9 exhibits and had 9 people initial by the exhibits you visited, that's another prize entry. And also, if you choose to make any donation and sign your envelope, that's another entry. Let's see. Please make sure you complete the first side of your yellow evaluation survey form, and after all the speakers, you can complete the back side where it talks about each of our speakers today. That is your lunch ticket. Do not lose it. We are very fortunate again today to have the golden voice of radio. She is Hawaii Public Radio's executive producer of talk shows and co-host of The Conversation and host of Town Square. Please welcome Beth Ann Kozlovich.
Good morning. Oh, that was a nice greeting. Thank you so much. It's really wonderful to be back here. How many of you were here with us last year? Hands up, hands up. Wow, a lot of new people. Maybe I should have asked the other question. How many of you are new this year? Oh, there you go. Well, Val Chang, you've done a splendid job of getting everybody out here this year. Really a pleasure for me to be with you. Also, a bit of a mixed feeling too, because this event is now in its 6th year, and not coincidentally, it's also the 6th year since I've lost my dad, and that's my connection to COPD. So it was a very, very rough go, as some of you who were here in last year's event or at other events have known, that my father's and his death and his battle with many issues having to do with lung disease drives a lot of what I do. And the fact that I'm on the air every single day and so much depend upon my good lungs, my good health, and my breath. It's a very good marriage, so I'm very happy to be here with you. And we have a really wonderful program today. We really, really do. I love seeing friends old and new when I come to this event, and we have a wonderful speaker who's going to kick off this event for us. Incidentally, she's also the chair of the event, and she is the very sexy and doctors shouldn't look that good. I'm sorry, Christine Fukui, but you just, honestly, every time I see you, you look gorgeous. But that's a whole other issue. What you need to know about her as far as talking to us today goes is that she is certified in pulmonology and sleep medicine. She worked for 29 years at Kaiser Permanente in Hawaii. Now she's at Tripler's Sleep Lab, and I'd like you to welcome her with a big, sexy hand. Thanks so much, Christine Fukui, for being here. Dr. Christine Fukui, it's always a pleasure. See, I wasn't kidding.
Okay, thank you, Beth Ann, for that really wonderful introduction. And I'm so glad that so many of you are here, and also that so many of you are coming here for the first time. So, because some of what I'll say this morning will be review for those of you who've been here before, but it's always a good reminder. So why are we here today? Well, COPD is a very important disease. It is the third leading cause of death in the United States and, in fact, in the world. And what is more important is that it is preventable and it is treatable. But you don't hear as much as you should about this condition that is so common. What is new? Well, for physicians, there are these things called the GOLD guidelines. They were updated in 2011, but these still have not been published, although they are available. There are also new medications that I will talk to you about at the end of the conference, some of which are available and some of which will be available soon. And I think people with COPD need to have a new attitude and consider, what can I do for myself and what can I do for others if you don't have COPD but know someone who does. So what is the new attitude? I think that's part of what we're talking about today, about taking care of yourself, that people need to take charge of their health and of their lives, and you should not let COPD and COPD patients be stigmatized by others, which it is. Both COPD and lung cancer suffer from their association with cigarette smoking. You never hear people with heart attacks get stigmatized because they smoked, when in fact that is, more people die from heart attacks that smoke than from COPD. But people never think about that. When they think about heart attacks, right, you think about, well, they had high blood pressure, they had high cholesterol. And 20% of patients with COPD have never smoked. So it's not just those people who smoke, it's people who have never smoked. And that's a significant proportion. So what is COPD? It's common, as I said, it's preventable and treatable. It's characterized by airflow limitations, so people have a hard time getting air out, and the condition is usually progressive, very slowly progressive. And why does it progress? It's because there is chronic inflammation in the lungs that is responsible for this condition. And when people have an exacerbation of their COPD, whether it's due to a cold or the weather or the fog or whatever, it contributes to the overall severity and decline. So prevention of exacerbations is very important, as well as treatment of comorbidities. And what do we mean by comorbidities? We mean things like heart conditions, etc. These are some of the symptoms of COPD. So dyspnea or shortness of breath, chronic coughing, chronic sputum production, and episodic worsening of the symptoms. So COPD, like asthma, patients have episodic worsening of their symptoms. The diagnosis. You see many patients who are diagnosed with COPD who have never had an objective measurement of their lung function. Spirometry, which is very simple to do, and some of you may have had your spirometry done upstairs, is really required to make a diagnosis. So if a doctor tells you that you have COPD and you have never had a breathing test, you need to ask for one, because that is really the only way that you can be certain that you have COPD and that you do not have another lung condition. Spirometry is also important to follow COPD. So if you have a baseline, then a year or two later you have another one, you can have an objective measurement of whether you are better, whether you are worse, or whether you are stable. And that too is very important. The way the doctor diagnoses it using spirometry is to give you a bronchodilator like albuterol, and then do the breathing tests, and if you still have airflow obstruction, you have COPD. Patients with asthma, when given albuterol, will improve, often to normal levels, normal spirometry. What causes COPD? Well, tobacco is right up there at the top, but this includes not only personal smoking of tobacco, but ETS, environmental tobacco smoke. So there are many people who develop lung disease not because they smoked, but because they were around smoke. And I have had several patients who never smoked, but their spouses smoked, and they developed lung disease and lung cancer. Everybody knows Superman's wife, right? She died of lung cancer. She never smoked. But what did she do? She was an entertainer. She was in clubs. She was in bars. And she was exposed to a lot of secondhand smoke. In many parts of the world, particularly the developing world, indoor air pollution is very important, and women in developing countries suffer disproportionately from COPD because of indoor cooking with fire and biomass fuels. There are occupational dusts and chemicals that people are exposed to. There is outdoor air pollution, and we all know the VOG affects breathing. However, in terms of trying to show that living in a polluted area causes COPD, it's very hard to show a large effect. So there have been many studies looking at the air, for example, in Lancaster, California, which is very clean, versus Long Beach, California, which is very bad. And it's been very hard to show in a population a significant difference. There are also factors that affect lung growth. This is primarily prematurity. When babies are born prematurely, their lungs suffer, and I have seen young children with severe COPD as a result of premature birth. The key indicators, most patients are over 40. They have the symptoms I mentioned before, shortness of breath, chronic cough, sputum, and they may have an exposure to a risk factor, tobacco, dust, and chemicals. There may be a family history of COPD, and that's very important too, and some of you may have visited the booths upstairs. There is a genetic form of emphysema called alpha-1 antitrypsin deficiency. I think that all patients with COPD should be screened for this because the treatment is very, very different for alpha-1 antitrypsin deficiency. You can find it in just about any racial group, but it is most prevalent in Caucasians. So I think particularly if you're a Caucasian and you have COPD, ask your physician, you should be screened, or you should have been screened at one point for alpha-1 antitrypsin deficiency. When a patient comes to see the physician, what should be assessed? Well, obviously symptoms, how short of breath you are, spirometry, not at every visit, but periodically spirometry should be performed, and prevention of exacerbations, because exacerbations really do result in decline in lung function. They also should look at comorbidities, like I mentioned, cardiovascular disease, osteoporosis, which is very common, depression and anxiety, and lung cancer, because lung cancer is more common in patients with COPD. This is the gold classification of COPD. You don't need to remember this. This is really for physicians. And it's based, again, on spirometry. So if your FEV1 is normal, greater than 80%, you're mild. If it's between 50 and 80%, you're moderate. Between 30 and 50% severe, and less than 30% very severe. And I'll have to tell you that I have a lot of patients that are less than 30%, and some of them were that severe at the time of their diagnosis, which means that the disease goes undetected for a very long, long time. What should be involved in therapy? Well, first and foremost, if you smoke, you stop smoking. Prevention, getting teenagers and even youngsters younger than that elementary school children not to smoke. Physical activity is very important. Medication, which we'll talk about. Vaccinations, yearly influenza shots, as well as the pneumococcal vaccine, which is protective against the most common cause of pneumonia. Doesn't mean that you will never get pneumonia after you get a pneumococcal vaccination, but it is helpful. It's a once-in-a-lifetime shot and is indicated for people over 60. But I'll tell you, I got a shot before I was 60 because I have seen too many young people die of pneumococcal infection. Antibiotics when needed, and rehabilitation, which you will hear a little bit more about after my talk. These are the therapies that increase survival. These are the only 3 that have been shown to increase survival. Oxygen. Oxygen is very important. If your doctor has prescribed it for you, you should use it because it increases survival. Ventilatory support. So this is not being in the hospital on a ventilator, but having BiPAP therapy also improves survival. And surgery, either lung transplantation or lung volume reduction surgery, also improves survival. And the criteria for lung volume reduction surgery are very, very specific, as well as for lung transplantation. But both of these surgical therapies will increase survival. All the other medications improve symptoms, but have not been shown yet to improve survival. So what are these medications? Well, the commonest are bronchodilators, and probably everyone with COPD is on a bronchodilator. Inhaled therapy is preferred because it goes directly to your lungs and there minimizes side effects. And these are beta-2 agonists, albuterol, anticholinergics such as Atrovent and Spiriva, and Theophylline, as well as combinations of these drugs. Long-acting medications, and I'll talk about that later, are more effective and reduce exacerbations, hospitalizations, improve symptoms and health. And combining bronchodilators from different classes, and we'll talk about that, is also helpful. We'll talk about steroids first. Steroids are indicated for more severe COPD. We're talking about inhaled steroids, and if you inhale it with a long-acting bronchodilator, they are more effective. Oral steroids, long-term particularly, are not recommended, but often when you have an exacerbation, your physician will prescribe a short course of prednisone, which can be very helpful in improving symptoms. What's new? So I decided that people know what they're taking. They want to hear about what's new. And for a long time, there was nothing, frankly, to talk about because we had had the same old drugs for a long, long time. Theophylline was being used when I was in medical school 40 years ago. That's how old a drug it is. It's been around for a very, very long time, and it's still being used. What does that tell you? Not very commonly, but it's still being used. It's still being used because there hasn't been a lot new. But just recently, there does seem to be a lot of new drugs. This is the one that is probably the most different. It's called roflumilast. The brand name is Dalla resp. You don't need to know its action. It's a phosphodiesterase 4 inhibitor. It's an anti-inflammatory, so it kind of works like steroids. It decreases inflammation. And in GOLD 3 and 4 patients, so those are the severe patients and the moderate patients that have a history of exacerbations and chronic bronchitis, it does reduce the exacerbations. And the effects are seen even when added already to inhaled bronchodilators. There are a bunch of new drugs that are new, but still in many respects are the same. But I'll tell you about them, and I'm even excited that they're coming on the market because that means that we have more choice in terms of medications, and maybe with some competition, the cost will go down. So, indacaterol. This is on the market. It's called our CAPTA, and it comes with its own special inhaler device. It's a long-acting beta agonist. It's very potent. It has a very quick onset, a very rapid onset. It is very similar to salmeterol, which is in many, many different bronchodilators combinations. Aclidinium was just approved about 2 months ago, a month and a half ago. The brand name for that is Tudorza Pressair. It's a long-acting anticholinergic, so it's like Spiriva. And it's used in patients greater than 18 years old, and the side effects are, cough, pharyngitis, very similar to many inhalers. This is probably the newest drug that has been approved. There are a whole group of drugs on the horizon that are ultra long-acting bronchodilators. They're ultra long-acting beta-2 agonists that only have to be given once a day. So most of the long-acting betas have to be given twice a day. These only have to be used once a day. So there is olodaterol that's being developed by Boehringer Ingelheim. It's delivered by its own very special Respimat inhaler device. And there's vilanterol, which is being developed by GlaxoSmithKline. There's combinations of these drugs, combinations of steroids with bronchodilators. Many of you are probably familiar with Advair and with Symbicort, which have been on the market for a long time. Combinations of steroids. The steroids are the first drug and the bronchodilator the second drug listed. There's now Dulera, which again is a steroid and long-acting bronchodilator. Dulera has not been approved for COPD use specifically, but can be used. It's very similar to all the others. And there is Relavair, which is new, fluticasone and vilanterol, which is a GSK drug, that very long, ultra long-acting bronchodilator that can be used only once a day. And Relavair will be the trade name. These are some that are being developed in the future, and these are combinations of anticholinergic drugs with long-acting bronchodilators. So they are similar to combinations of, for example, salmeterol and Spiriva, but these are new. Now, it's kind of interesting. Glycopyrronium and glycopyrrolate are in fact the same drug, and in fact this drug has been around for decades and is not even patented anymore. It's lost its patent many years ago, but it's being developed as an anticholinergic and combined with these long-acting bronchodilators, indacaterol, olodaterol, and formoterol, being developed by different drug companies. And that's the end of my presentation, and if there are any questions, I would be happy to answer them. Anybody? The roflumilast, because it's different, because it's a totally different drug. Although it'll be interesting, especially that last slide, to see some of the new anticholinergics and see whether they're better tolerated or more effective. And I think just having a variety, gives you at least some choice in terms of combination therapy, and particularly once-a-day therapy, which is much more convenient for people even than twice-a-day therapy. Twice a day is not bad, but once a day is even better. Yes? What? Well, they're mostly in stage 2 and 3 clinical trials right now. Well, probably several years, yeah. Probably several years down the road. Yes?
Does marijuana, cigarettes have the same effect?
Good question. Hard to study because almost no one smokes as much marijuana as they do cigarettes. That's number one. They have tried to do studies in, there is this religious group that uses marijuana. so that's one issue. I don't think anyone smokes as much marijuana as they do cigarettes. And number two is the way of smoking it is usually very different too. So it's, I think it's hard to know. Oh, it's very similar because it's an irritant. So in other words, you can take the active ingredient of marijuana in a pill form, and actually it's a prescription drug that's given to cancer patients. No, no. I mean, it's the irritant effect of the smoke. I don't think anyone studied marijuana in terms of. I don't know that you could say that it was less harmful because, no. It's an illegal drug. So, I think it, I don't know that you could say that it was good for people, and I don't know why, like I said, they've only studied in this one group of, it's a religious group in the Caribbean that uses marijuana, a lot of marijuana, but it was very hard to show much, both because the amount, as I said, smoked was much less. You don't see people smoking 20 joints a day. Oh, I have another question. It's the forced expired volume in 1 second, and it's a measure along with the forced vital capacity of how much air you can get out quickly. So the major defect in both COPD and asthma is that the amount of air you get out quickly is decreased.